Good morning to all. Today I will be talking on pediatric refraction. As we all know, refractive error is the most common cause of visual impairment in 60 to 80% of the children. And early detection and management of refractive error helps to achieve optimal acuity, binocularity, and overall development of the child. Inappropriate refractive correction will hamper the child's optical and neural development. The challenges that we usually face in pediatric refraction is because of the limited cooperation, low reliability, and because of the children have greater range of accommodation, difficulty in quantifying the visual status, and because of the risk of amblyopia. So, objective refraction is preferred than subjective due to this limited reliability and strong accommodation of the child. So, how to assess refraction? Visual assessment is usually age appropriate. Less than 2.5 years of age, you usually assess with fixation and following of movement or with light. Preferential looking charts like Cardiff cards can be used. And objection to occlusion and fixation preferences also is used to assess the refraction. And 2.5 to 4 years of age, symbols or alphabet matching cards like Allen's card, HOTV and LIA symbols can be used. Above 4 years, Snellen or Logma chart can be used. Pediatric refraction assessment is not complete without the complete eye examination, and hence it's mandatory. And it includes Hirschberg test, cover-uncover test, EOM assessment, convergence, complete squint examination if detected. Anterior segment examination, fundus examination with objective refractive method like retinoscopy is mandatory. Now the indications of cycloplegic retinoscopy. It is indicated in every non-verbal child, young patient with symptoms but no refractive error, young children, those with strabismus, and those child with accommodative asthenopias, and those we suspect pseudomyopia or latent hyperopia, and when there is a poor reliability between the objective retinoscopy and subjective. So cycloplegics, as we all know, the mainly used cycloplegic in children is atropine, homatropine, cyclopentolate. Cyclopentolate 1% is preferred routine use in children, and cyclopentolate 0.2 to 0.5% can be used in infants. In some ophthalmologists use atropine 1% for younger children with ESO, and because of the many side effects and prolonged blurring, it should be used only in these children with ESO. A regimen that is commonly used that have comparable cycloplegia as atropine 1% is a CTC regimen. That is cyclopentolate 1% instilled twice, followed by tropicamide 0.8% with phenylephrine 5%, 5 minutes apart. And the retinoscopy can be performed 45 minutes after the first drop instillation. As we all know, cycloplegic have a number of side effects, and it should be always avoided in children. Overdose of cycloplegic agent should be always avoided in children with Downs, cerebral palsy, trisomy 13-18, and CNS disorder, as it can be hallucinogenic. The American Association of Pediatric Ophthalmology and Strabismus has guidelines for prescription of glasses, and they have classified the children according to the age, and the diopters beyond which the glass should be prescribed is considered depending upon the refractive error of the child. And there is also a national consensus for the minimum refractive correction to be prescribed in infants and young children. We'll be dealing with it in the coming section. So the gold standard is always objective refraction using retinoscopy. Prior to the glass prescription, we know the refractive status of the child is constantly changing with age. Hypermetropia should be always corrected early than myopia because the children are usually into near activities. Child less than 2 years, minimal myopia, there is no need of any correction. Risk of amblyopia depend on the magnitude and type of refractive error as well as the age. And anisometropy is the most common cause of the amblyopia. Cycloplegic refraction and in associated strabismus should also be considered before prescription of glass. Then each refractive error per se, hypermetropia, it should be corrected earlier. And more than 5 diopter, usually the child can present with asthenopia. So if uncorrected, refractive accommodative ESO and amblyopia can develop. In infants less than 6 diopter, usually there is no correction given according to the American Association of Pediatric Ophthalmology and Strabismus guidelines. In children with no ESO, mild undercorrection can be given. ESO with high AZ by A ratio, full cycloplegic correction with bifocals is mandatory. Myopia, less than 4 diopter, no correction is required in infants. But 3 to 4 years of age, you should prescribe even for lower degree of myopia. You should always avoid overcorrection and prescribe lowest minus powers. In presence of intermittent EXO, even the smallest myopic correction is prescribed. In astigmatism, it's not overcome by accommodation. Hence, power of more than 1.5 diopter to 2 diopter can be amblyogenic and it should be prescribed. Children usually accept high cylinders more easily. So spectacle fittings and centration is very important in high cylindrical powers. Anisometropia. Hypermetropic anisometropia and cylindrical anisometropia are more amblyogenic. A difference of more than 1.5 hyperopia or astigmatism need to be corrected. But in myopia, a difference of more than 3 diopter needs correction. If amblyopia is already present, amblyopic treatment is mandatory. In aphakics and pseudophakic, overcorrection by 2 to 3 diopter is recommended as a child is more into near activity. By 1 year post-op, you have to reduce the overcorrection by 1 to 1.5 diopter, and by 2 to 3 year post-op, bifocals can be considered. Okay, thank you.
Thank you, Dr. RUKZANA. So there is a slight rearrangement in